I'm very delighted to be presenting this webinar with Mirjana. I'd also like to start by acknowledging the traditional custodians of the lands we're meeting on today, which for me is in Sydney, so the Gadigal people of the Eora Nation. I pay my respects to elders past, present and future, and would also like to acknowledge and welcome any Aboriginal and Torres Strait Islander peoples who are with us today. And I'd also like to acknowledge and pay my respects to people with lived experience of trauma, substance use and or mental health conditions who are here as well. So I've been asked to present on the topic of trauma and substance use, an issue that is very close to people's hearts and as evidenced by the number of people who registered as well. And it's very close to them, often either in their professional roles or perhaps on a more personal note in relation to your own experiences or those of people close to you. I'll be talking quite broadly today about 3 areas on the screen, but I'll just touch on the first point relatively briefly, just for those who might not be as familiar with the area, but spend more time discussing the evidence in relation to the link between trauma and substance use and approaches to management and treatment. But even these broad conversations can sometimes be distressing for people or affect us in unexpected ways. So please feel free to drop in and out if you need to, or take a break, or you can always catch up in the recording afterwards. Also note that I don't actually have any specific expertise in relation to refugee trauma itself, but I hope that this information is nonetheless useful to you, and very interested because I will learn a lot as well from Mirjana's talk, but also I think from all of you in the discussion as well about how this fits with your clinical experience. So, just firstly, the term trauma is used fairly commonly and very broadly by people when referring to a range of occurrences, from something that might have happened that's mildly distressing all the way through to something very horrific and life-threatening. So when I'm talking about trauma tonight, I'm talking about either a single event or a series of events where a person believes that their own life or safety or that of someone else is at serious risk. So by either experiencing it themselves or witnessing something happening to other people. But regardless of the type of trauma and whether or not it's a one-off or prolonged, they can be life-changing, redefining moments for people where they may completely change their views about themselves, the world around them, and also how they relate to it. And for those who are unfortunate enough to have experienced it during childhood, these beliefs may be particularly well entrenched. The consequences can be very broad and long-lasting, including disturbances in regulating a person's emotions, their cognitions, their memory and belief systems, which consequently can impact adversely on multiple life domains, so including education, employment, relationships, also the likelihood of engaging in particular behaviours, aggression, being imprisoned, homeless, having chronic physical health conditions, as well as substance use and mental health disorders. And again, this impact is particularly pronounced if there are multiple traumas in a person's history or if they've experienced trauma during childhood. Childhood trauma has consistently been found to have very strong and enduring associations with all classes of mental health disorders across the lifespan and across the world. The US Adverse Childhood Experience Study has been really pivotal in improving our understanding of the impact of child trauma, as well as other adversity, on the development and long-term outcomes relating to physical health, mental health, and psychosocial functioning in terms of employment and relationships. So this was a very large study conducted in the 1990s on over 13,000 young people, which found that, sorry, not young people, adults, but reflecting on their youth. And they found that adverse childhood experiences were associated with increased rates of alcohol and other drug use, earlier age of onset of use, as well as poorer mental health and higher rates of attempted suicide. And there's also a dose-response relationship observed. So the risk of occurrence and severity of each of those outcomes described increase with the number of adverse events experienced. A similar pattern has emerged from analysis in Australia of the National Survey of Mental Health and Wellbeing, where we have 1/3 of adults reporting exposure to childhood trauma who have developed an alcohol or other drug use disorder, which is previously referred to as abuse and dependence, but now in the one category of use disorder, and it's predominantly alcohol and cannabis. And that rate is nearly 3 times that of adults who've never experienced trauma, and 1.3 times that of people who have experienced trauma but only ever in adulthood. But the most common mental health condition to develop after exposure to trauma, or that which can be directly attributed to a traumatic event, is PTSD. And many of you will be familiar with that condition, so I won't go into the symptoms, but we'll just reflect on it, or remembering that it's essentially an adaptive response to fear that has become maladaptive in the responses that in the presence of a potential threat can keep you safe, but become problematic when that alarm is activated and being set off in situations where there is no threat and where it's starting to impede a person's life and their functioning. Before talking about PTSD in more detail, though, I just wanted to note as well that people with PTSD tend to have high rates of other mental health conditions, including depression, anxiety, borderline personality traits, and some, perhaps around 1 in 2, may also experience a more complex form of PTSD. Complex PTSD has only recently been recognised as a distinct disorder in the latest revision to the International Classification of Diseases, but it has a very long history of advocacy over the last 30 years. But because of there being quite a bit of difference in terms of how people have conceptualized it, the research available at the moment doesn't tend to reflect this concept as it stands now. But the reason I say that is just for people to bear in mind, though, that whilst I'm about to present research in relation to PTSD and people with that particular diagnosis, a considerable proportion of those people would actually also meet criteria for having a more complex PTSD presentation, where they're also having difficulties with affect regulation, their negative beliefs about themselves, and disturbances in interpersonal relationships. So just going back to PTSD, who develops it? Important to remember that while a large number of people will experience symptoms in the immediate aftermath of a trauma, most of those will subside quickly within 1 to 3 months. And that is reflective of the natural processing that a person would go through after exposure to something traumatic and confronting. And in Australia, only about 1 in 10 people who've experienced trauma go on to develop a PTSD diagnosis. And for half of those people, that will be before the age of 26. There are a number of pre-trauma factors that affect a person's susceptibility to developing PTSD and having those more prolonged symptom experiences. And with the exception of sex, it's worth noting that these are also factors that are common among people who develop substance use disorders. So having experienced multiple traumas, having a personal or family history of another mental health conditions, low social supports, and other factors related to the trauma itself can impact a person's susceptibility, including the experience of distress at the time of the event and whether or not it was interpersonal in nature, but also how affected they were in the immediate aftermath. So whether they had ongoing complications, how much social support they had, and also importantly, avoidance, which brings me to substance use. So I briefly mentioned earlier that substance use commonly co-occurs with trauma exposure, but its development is typically mediated through the development of other conditions such as PTSD. So by that, I mean, it isn't necessarily the experience of the trauma itself that can lead to an increases in problematic substance use, but rather the problems a person develops as a result of the trauma that can increase their risk of problematic substance use. Findings from the Australian National Survey of Mental Health and Wellbeing that I mentioned has shown that in Australia, 65% of men with PTSD and around 1/3 of women with PTSD also have a co-occurring substance use disorder, which is a huge chunk of people with this condition. And more recent analysis of that survey has also shown that the odds of transitioning from using a substance to developing a use disorder increased about twofold by the presence of PTSD. Earlier research collected on the first national survey conducted in Australia also gives us more of an idea about difference in prevalence of these comorbidities depending on drug type. So we'd found the most common substance use disorder among people with PTSD is alcohol. Not necessarily too surprising, given that that is the most prevalent substance used within the population more broadly. But only 5% of people with an alcohol use disorder have post-traumatic stress disorder. So when you look at it specifically among people who have substance use disorders, PTSD is more common among those with opioid, sedative, and amphetamine use disorders at 33, 29, and around 24% respectively. And these are the substances that are most strongly associated with PTSD, and rates that are considerably higher than that observed in the general population. When we look at rates of PTSD among people who seek treatment for their substance use, we find that trauma exposure is almost universal, and that the vast majority of people are experiencing multiple traumas. Our research has shown around 4 different trauma types, let alone the number of repeated episodes within trauma type. But up to 2/3 of Australian clients of alcohol and other drug treatment services have been found to be experiencing current PTSD when they enter treatment. There also tend to be high rates of childhood trauma. In a trial that we conducted looking at adults who are seeking treatment for substance use disorder and PTSD, we found that for 25% of those people, they experienced their first trauma by the age of 4, and for 50% by the age of 8. Their PTSD tended to be very chronic, severe, and despite that, though, very few had actually accessed care for their experiences. For many people, self-medication plays a critical role in the development and the maintenance of a substance use disorder. And the self-medication hypothesis postulates that substance use disorders come about as a result of repeated substance use in an effort to try and ameliorate some of those PTSD symptoms that they're experiencing. And I'll just note that it's sort of similar to how I mentioned earlier about the description of PTSD, in that it's an adaptive response. It's a response that people tend to resort to in an effort to cope with what they're experiencing. But through that repeated use and the development of a substance use disorder, it's become maladaptive for them. But consistent with this, for those who do develop substance use disorders and PTSD, for about 2/3 of men and half of women, the PTSD does have its onset prior to when a person starts to develop symptoms of a substance use disorder. And the very limited research that has been conducted among refugees in Australia also indicates that that is likely to be playing a key role for this group particularly as well. But there are other theories linked to why there is such high rates of substance use disorder in people with PTSD. The other one is a high risk hypothesis, which puts forward that people who have substance use disorders, particularly those who are perhaps using illicit drugs, may have a more high risk lifestyle, therefore increasing the likelihood that they'll be exposed to trauma. and therefore more likely to develop PTSD. There's also the susceptibility hypothesis, whereby it's thought that people with substance use disorders lack other coping skills to be able to to be able to deal with trauma in the event that it happens, so they're more likely to develop PTSD. But there's also relates to physiological susceptibility as well, that from repeated episodes of intoxication and withdrawal and the dysregulation of the stress response system, that is effectively priming a person to being more susceptible to PTSD in the event of a trauma. And as with all co-occurring conditions, there's the common factors hypothesis that there may be common factors that underlie both conditions, whether they're biological, psychological, sociological. But importantly, regardless of why or how a person came to develop both conditions, once they are established, both tend to maintain and exacerbate each other in a fairly vicious cycle. And they become very integrally related. Studies that have examined how changes in symptoms of one disorder impact on symptoms of the other have also shown that improvements in PTSD symptoms often lead to improvements in substance use. But the reciprocal relationship doesn't tend to be observed. So even if a person is able to achieve very substantive reductions in their substance use, PTSD symptoms don't remit. And on the contrary, it may be that their PTSD symptoms actually worsen in the absence of substance use, particularly if it has served some self-medication function for them. And that can make it really difficult for a person to sustain abstinence or continue to have reduced use when their PTSD symptoms are starting to elevate. And it really highlights the centrality of addressing both PTSD and substance use when it's co-occurring, and also why, merely sending someone perhaps off to a withdrawal unit or detox facility is not likely to be very successful in the long term. But in addition to the distress associated with a person experiencing their symptoms of their substance use disorder, their symptoms of their PTSD, they're also often coming with poorer physical health, poorer psychosocial functioning, poorer psychological health. So coming into treatment settings with a more severe clinical profile, and also demonstrating poorer treatment outcomes, particularly in those domains that I'd mentioned. So it's quite crucial that we do manage and treat it appropriately. Having said that, though, it is important to acknowledge that it's not surprising, given that profile, that clinicians both in the US and here in Australia have been found to report that it's really challenging for them, and they're not exactly sure how to best do that. So what do we know about how best to manage it? Well, I should probably start by that there has traditionally been a reluctance to address trauma-related symptoms and PTSD among people with substance use disorders, due to beliefs about them being too vulnerable. And this comes as a... Sorry, my 1 second. Sorry, I am now the only person in the building, so the lights aren't going to stay on for very long. Sorry, but there has been some reluctance for among clinicians, but mainly out of a genuine concern that they don't want to cause harm, and they are worried that people may relapse, or they might deteriorate in their mental health if they do start to try and address the trauma whilst they're still using substances. And in some cases, people have advocated for prolonged periods of abstinence, often up to 6 months, before being willing to address PTSD. So the sequential model of care has been the predominant one. But what tends to happen is that people with, as I mentioned, as they start to reduce their substance use, their PTSD symptoms start to increase, and then they find it very difficult to maintain that. So it ends up that they actually never end up having their PTSD treatment. But and then they're just falling through the cracks. But research now is focusing more on integrated treatment, so treating the substance use and PTSD at the same time by the same clinician. And this is something that clients also indicate that they would prefer, and it's also more efficient. And it's important to also realize that ongoing substance use, whilst it may impede therapy, it may be slower than what you would normally be used to. It's not necessary to achieve abstinence before commencing PTSD treatments. You can still obtain improvements, which I'll talk to in a minute. So there has been a growing number of studies examining integrated treatments. And how do you address trauma symptoms safely and effectively when a person also has substance use issues? And those existing approaches can generally be divided into two different types: present-centered or non-trauma focused therapies, or past-focused or trauma-focused therapies. And the former tend to be ones where it's concentrated solely on what a person is experiencing currently, and providing them with coping skills, but does not involve addressing the traumatic events itself. And if anything, actively steers them more away from doing so. Whereas trauma-focused and past-focused therapies do tend to confront what has happened in the past to work through that. And there had been a Cochrane review undertaken on all of the research in this area in 2015, which found that there was actually very little evidence to support the present-centered or present-focused therapies, and that past-focused therapies delivered alongside alcohol and other drug treatment can reduce PTSD severity and substance use. So for that reason, I'll focus here on those past-focused therapies, which have typically delivered individually and include the use of exposure-based techniques in which the person is exposed to reminders of the trauma, either people, not so much people, but feared objects or situations, things that remind them in the event, as well as their traumatic memories. Importantly, though, in terms of the objects and situations, it is not about exposing a person to anything that is objectively dangerous, not about confronting the perpetrator or anything like that. It's more about addressing avoidance, its impact on a person's ability to live the life that they want to. And again, traditionally, those exposure-based therapies for PTSD were steered away from in relation to substance use, based on the beliefs that the emotions elicited during particularly those imaginal exposures where the person is retelling and reliving what they experienced in session with their therapist, the distress there would be too much for people to handle, and that it may lead to relapse. But on the contrary, it's actually been shown to be protective with regards to relapse up to 6 months post-treatment. And support for these types of programs has been growing, with an increasing number of studies providing evidence of their safety and efficacy, 2 of which have been conducted in Australia. One by Claudia Sanabale that I was involved in as well, looking at integrated CBT for PTSD and alcohol use. And another one we conducted looking at a treatment called concurrent treatment of PTSD and substance use disorders using prolonged exposure. And that was a world first RCT that we conducted with colleagues from the Medical University of South Carolina, who had developed an earlier form of this treatment in the 1990s. And we had looked at this in a sample that was quite severe in terms of clinical presentation. 100% of the sample were substance dependent. Most common drugs that they were dependent on were heroin, cannabis, amphetamines, and benzodiazepines. But they were using, on average, 4 different types of drug classes. 80% of them were injecting drug users. And they also experienced high rates of other mental health conditions, including severe depression, high rates of screening positive for borderline personality disorder, and rates of attempted suicide. And you could imagine actually starting that trial, it was with obviously care and concern that we conducted it. We were also not sure how this would go. But we found that there were actually significant reductions in PTSD symptom severity among those who did receive the integrated treatment relative to treatment as usual. And that was accompanied by reductions in the severity of their substance use disorder. Not only did we see shifts, though, in their severity, but also diagnostic shifts. So close to 1/2 of those who were receiving the integrated treatment, which was delivered over 13 sessions, no longer met criteria for a diagnosis, compared to 20% of those in the treatment as usual control condition. But we think that those rates probably would have been better if there was more prolonged treatment available to them. Importantly, to note that about 75% of the people being treated continued to use substances throughout, albeit at a lower rate, but they were using something. But nonetheless, improvements were obtained. And we also found that it wasn't whether their changes in PTSD symptom severity wasn't affected by whether or not they had other co-occurring conditions, what type of trauma they experienced, or the number of substances used. And we need more research in this area, but it does give us at least some preliminary evidence of it being broadly applicable to different types of clinical presentations. Participant feedback was also very positive. Many people had never spoken about what had happened to them before and hadn't really realized about how their trauma and their substance use was linked for them. It often hadn't been broached with them in the past either. And many of them finding that they could do things that they hadn't been able to do in years because they had managed to work through their trauma. And although doing those imaginal exposures was the hardest part, it was often reported as the most useful for people. So that treatment has since been published by Oxford University Press as part of their Treatments That Work series. And there's been a lot more work done, particularly on that therapy, making it the most researched past focused therapy for PTSD and substance use disorders. And it's been examined in the US and Sweden, in general population surveys, as well as with veterans. And at the moment, there are also 2 other implementation trials that are being conducted, in one in northern New South Wales and one in Melbourne, looking at how it works in more real-world treatment settings. We are also currently conducting a trial among young adults and adolescents. As I mentioned, the PTSD, well, both PTSD and substance use disorders tend to have their onset in adolescence and young adulthood. So ideally, we need to be getting in earlier, intervening before they become those chronic relapsing conditions and mutually maintaining into adulthood. But to date, there hasn't been any empirically validated treatments for this population. So we are currently conducting one with funding from NHMRC and Rotary Health. And if anyone is interested in that, please feel free to get in touch or have a look at the link there. There are, however, a number of other trauma-focused therapies that are being researched at the moment, looking at different methods that or ways of delivering exposure-based techniques, including modified versions that have additional motivational enhancement sessions, various ways of using EMDR or EMDR plus schema therapy, as well as CPT approaches. So it's quite exciting that there are a number of different ones being examined, because no one therapy is going to work for everybody. And I'm certainly not saying that the presence-centered therapies don't have a place for some clients. They absolutely do, and that may be all they're willing to do as well. But it's so important that we do have a range of things available for people. So just to sum up very quickly, trauma exposure and PTSD and substance use disorders are common and associated with some significant harms for people, and often poorer treatment outcomes in some domains. But there is hope. There is growing evidence demonstrating safety and efficacy of trauma-focused treatments. Participants have not got worse. And on the contrary, they tend to demonstrate significant improvements. There are still, though, a lot of challenges and gaps. For example, how we build resilience in young people and adaptive coping strategies for adverse events, how we support people to seek help when they need it and intervene early, And how do we incorporate those evidence-based treatments into practice, moving further beyond trauma-informed care to trauma-focused care? And also, very importantly, needing to address those knowledge and practice gaps, particularly with high-risk populations, such as refugees. Thank you.